just excuse me, I will share the screen هنعمل introduction and then I will give you the chance
اوكي.
تبدأ.
سوري ستوب شيرنج. اوكي.
Assalamu alaikum. Hello, everyone, and welcome to our series on diarrheal disease echo. I am Dr. Sarah Adam, the program facilitator. My colleague, Dr. Ahmed Kayak, is the program coordinator. And for today, the session will be about managing complications and severe cases regarding the diarrheal diseases and um, mainly the cholera. Um, we have 5 minutes. We'll give some housekeeping rules, and then we'll have the didactic with our guest, Dr. Nagi Elsadig. Then we will open the floor for a discussion. Uh, want to hear your questions. The participants in today's session are from ECHO India and attendees from Bushra Ibn Auf Center for Learning and Humanitarian Relief Support in Port Sudan. And also we have virtual attendees. There's some Zoom features and etiquette. Um, this is the view you have in the Zoom. You can rename yourself from this bottom, and down in the bar we have the chat. If you have any question or you want to introduce yourself, just click on the chat. Here you can share the screen and this button for muting or unmute. Another way to rename yourself by clicking in the participants button, just beside your name, click here. You will find the choice rename. This is an ideal way. We prefer in naming yourself just for better identifying. Write your name, then your institute, then your location. And if you are more than one, you can write the number of extra participants. Um, please introduce yourself here in the chat. Give your name, designation. Um, you can also mute when not speaking and position webcam appropriately if you prefer. Put your phone on silence and please raise your hand to ask any questions. And don't mention any patient's name, just to keep the confidentiality of the patient data. Discussion makes this work the best. We like the two-side learning, so we will enjoy sharing expertise with the attendees. So in the part of discussion, welcome to any questions. This session will be recorded and will be sent to you at email just after the session. Now our subject matter expert, Dr. Nagi Elsadig, he's consultant pediatric infectious diseases at Sultan Qaboos University Hospital in Muscat. Welcome, Dr. Nagi. We are so happy to have you, and the floor is yours.
Hi everyone. But while Dr. Nagi is sharing his screen, I just want to let you know that we have prepared a feedback form for the course. This feedback form is going to be posted on the chat box. Please fill it out. We really want to know your opinion and feedback about the course and ways of improvement. Thank you.
السلام عليكم ورحمة الله تعالى وبركاته. How are you everyone? I am Dr. And today I'm pleased to be here with you to discuss some issues regarding the cholera. Actually here concentrated mainly on the complication and severe cases, and both of them are related and related. I will start by thanking Sama for giving me this chance to contribute with them. They're doing a lot of excellent, outstanding efforts to help our people in Sudan, beloved country. And also I would like to thank all doctors, healthcare workers, nurses, and allies in Sudan who are facing a difficult time, but they're doing their best to keep life of people of Sudan in better shape. So, is it moving or not moving? The slides not moving for me. Assalamu alaikum. Yes, okay. So starting, as you know, cholera is distinct in its character and pathogenesis, like it is kind of causing secretory diarrhea because the toxin mediated and making all fluid from the intestine be pumped out from the body. Like, so that's why one of the major features of cholera is significant hypovolemia and severe dehydration like that. So even if the body is not getting any water or any fluids like that, still the excretory mechanism is going to work like that, depleting the body from its sources of water. So cholera is that's why it is rapidly dehydrating diarrheal disease, and we know that it's caused by Vibrio cholerae. If not treated quickly, it leads to high morbidity. Actually, the morbidity maybe without treatment reaching can be up to 50%. We know that some of the cases of the cholera are less symptomatic or sometimes asymptomatic, but most of the cases when the symptoms started, especially for severe cases, the mortality rate without intervention reaching up to 50%. But fortunately, most complications are preventable with early detection. So the earlier detection and early intervene for the course of the disease, the better the outcome for sure we can get it. So this makes us with good hope like that we can survive or saving a lot of life and decreasing morbidity as well as mortality. We know that it's not Sudan is not an exception. It happened in many countries before when there is a conflict, war, or whatever like that. There is possibility for the cholera to increase because especially there is pressure for resources. It will be limited. Health system will be collapsing. And the sources, and above that, the sources of the clean water will be highly affected, which is happening in Sudan. For sure, this was been spoken before in or presented before with my colleagues who are expert in the field about highlighting the epidemiology of these things. But just in one slide like that, just to show that the problem is still ongoing. The outbreak in Sudan started actually in August, as we know, 2024, actually announced in 12th of August at that time when it started in Kassala state, when announced the outbreak of cholera. And from there, it started to spread to other states, reaching up to 11 out of 18 states, like that. Some states are heavily affected, like, White Nile, Kassala, Gadarif, and Al Jazeera. And the main drivers, as you know, like the conflict which is happening now, and affecting all the structures of water facilities to with high impact on that. Many hospitals, more than 80%, are non-functioning conflict zones, overcrowding, refugees places, difficult to get clean water. All these things affecting the spread or making the outbreak to happen and too difficult to control. But thankfully, there is a lot of effort from Sudan, from allies, community, international community, presented mainly in the WHO and UNICEF, leading to emergency health, water sanitation efforts. And there is started a huge campaign for vaccinating cholera. Now we reach almost around 67% coverage in Sudan. The situation little bit came better. But still we are in the risk and still it is fluctuating. Like in this year at January, the cases was decreasing, but it started to increase again in February and March, again start to little bit decrease, and we don't know, now we are going to summer and the rainy seasons like that, and still there is a lot of problems. So still we have to be very ready to do our best. The best things is to tackle this complication is to understand who are the population at risk, so we can tackle them from the first time to encounter us with symptoms or either proven or suspected cholera. So there is many population or subpopulation who are more affected by cholera will be in severe complication. One of them is children, and all of them, there is like, when you think about each one of these groups which is mentioned here, you'll find that there is something we'll add to. For children, for example, children especially who are less than 5, they're more prone to dehydration because of their large body content of water, and also for the same time their need for hydration in comparison with adults, per kg, and for sure per kg of body weight. They're also prone more to hypoglycemia as well as the electrolyte disturbance. Elderly, because already many of them they having comorbidities affecting other parts of their body, so we can find there is some kind of like reducing physiological reserve of them. So this will add more for the something is going to hit their body by like cholera, which is hardly debilitating illness, causing severe dehydration and electrolyte disturbances. Malnourished individuals who are already having a kind of malnutrition, especially those who are having severe, they are also at high risk of poor recovery, more prolonged and more severe course, as well as there are also at risk of refeeding syndrome. Refeeding syndrome is something like many times is underestimated or undertackled like that, or overlooked. And it is very important to look for it, especially for all people who's having cholera, who's this severe or continue for a long time, especially who are malnourished. When it start, and usually the problem start after the symptoms of the cholera and signs start to improve. Pregnant women also are vulnerable also to get severe dehydration and other issue, and we have to remember that pregnant women, they having also a fetus. So both of them are affected. So the fetus also can be affected. They can get fetal distress. So they are vulnerable to get severe dehydration also because of the way of the distribution, tissue distribution of fluids and these things like that. People who are having chronic illnesses for sure, regardless of the age, especially who are like having kidney diseases, heart disease, lung disease, or whatever, they also at high risk, and almost because of this already affected physiological reserve. So this kind of, maybe this is not all, but this is things we have to concentrate on, who are people who are, or population at risk to get more complications like that. So when like we are in a camp or we are in a campaign or we are seeing in the clinic, whatever like that, we have a child or we have an elderly man or malnourished or pregnant, we have to be very cautious about the complications. The burden of cholera mortality and on morbidity about the complication. Actually, the case fatality, as we mentioned before, it can reach up to 50%. While with adequate treatment, the case fatality, usually it can be down to less than 1% or 1% maximum. And usually this is the WHO target. And usually the WHO is target. And now our target in Sudan, with this outbreak, also to come down with mortality is less than 1%. Currently, so far, the updated information or reports like that, the mortality in Sudan is around 2.2 to 2.5. So it is around 2.2 plus like that, okay? So still there is area to be done, but we cannot ignore or underestimate the high effort of people who are working in Sudan, because without their good care, you know, like the case fatality without treatment, it can reach up to 50%. And as I mentioned before in the previous slides, the children also are highly affected. And actually in Sudan, there is a lot of children who died among these who died from cholera. And the main cause of this is severe dehydration, maybe followed also by electrolyte disturbances. As I mentioned, electrolyte imbalance, renal failure, impairment, these things can add to morbidity and mortality. So it's not only about dehydration, but also we have to think about electrolytes imbalance beside hypoglycemia issues, and especially hypoglycemia can happen more in children, and especially children who are less than 5 years. We have to be in our mind like that. It's better like that, you know, as the phrase or basal is درهم مقار خير من قنطار علاج. So the better things is to avoid the complication before it happens. So one of the things is delayed treatment. So treatment as soon as possible, it will decrease the mortality, morbidity, and also decrease the complication, because complication once it started, it will be more difficult to to tackle or to control it like that. So this is very important about looking for these things. Like for example, for a hydration, we don't have an IV access. We start with NG, nasogastric. If no nasogastric or whatever like that, at least we sip. So the sooner the better like that to tackle with the properties happen and to avoid also like other issues like for example malnutrition or whatever. So now we go to the complications. Okay, one of the major complications can lead to morbidity and mortality is severe dehydration, which is also cited with hypovolemic shock. And as you mentioned, and as you know, sorry, there is a clinical science here, which is very important. Because in resource limited situation, with difficulties like that, so we depend on our clinical sense mainly, and in many things. And I believe that our Sudanese doctor, nurses, healthcare workers, and all they having a good clinical sense and clinical judgment like that. So this wanted to help us to identify the problems early, because there is many issues regarding, like the equipment of laboratory and these things. And even if it is available at times, sometimes it will need to be sent away until to get the results. And the situation of the patient is not going to wait for you for that. So the intervention should be fast as possible. So like clinical signs, as we know, it is same like severe dehydration, but sometimes when the patient is going to shock, like in a state of lethargy, maybe even he will be unconscious or out of consciousness like that. Urine output in a state of decreasing also sometimes can be also, there is no urine output, all these things. How to manage this for hypovolemic shock? For sure, like severe dehydration also included, but for the shock, we need to give also initial, like maybe we need to give normal saline will be counted for the all amount of fluid should be given. For sure, usually the most fluid, IV fluid, is recommended for cholera, and even by WHO is regular lactate, because of it is content of also potassium. So it is more suitable for cholera than other IV fluids like that. So we have to remember that for infants, usually for infants, because their cardiovascular is a little bit compromised in comparison, they cannot tolerate high amount of fluid per their compared to their weight. So usually gives them, it is all in 6 hours. The 30% or 30 ml, it will be like in the first hour. While from 1 year and above, including also for adults, the time can be shorter, than total in 3 hours, 30 in the first in half hour, and the rest in the remaining of the time. Say, okay, many times children like is coming, or adult, whatever like that, they especially, we know that it is like they come with severe dehydration. So sometimes even initially it will be very difficult to get an IV access like that. So we should not, and we should take all efforts to start hydrating the patient, because cholera is highly depleting of the body water or content of the body fluids like that. So we can start with, if there is no IV access, we can start with putting a nasogastric tube, and we can start giving fluid through it. If the patient can tolerate, make sure that the patient is conscious, because the patient unconscious, maybe there is a risk of aspiration, or at that time can get the aspiration pneumonia or aspiration on other problems like that. So if the patient can take, also we can give small sips of water, sorry, of ORS. We avoid plain water. So this I'm trying to give it, in a short and concentrated, because I know most of you, they having good idea about how to deal with things, but we are putting the complications all like in one box. So it will be like easy for us when tackle each patient to think about which is which like that, and which things in this patient we should concentrate on in comparison with the other patient. Next one, we'll speak about complication of hypokalemia. All the rare diseases can cause hypokalemia, but for cholera, it's well known that can cause, because the amount of loss and fluid loss from the GI is significant. So by each amount of water lost from GI, there is amount of potassium will be lost also later. And and as we mentioned, you have to look for the clinical science mainly, because many times we don't have the availability of the lab. And the lab, even if you have, it will take till the collecting the sample, send it to the lab to get the results. So you have to interact and you have to take your clinical science and clinical judgment, which is very important like that. So the clinical signs of hypokalemia, maybe not all, but one of the major is like muscle weakness, hypotonia, paralytic ileus, and fatigue like that. So you can, like all things related to weakness and decreased movement. That's why you can see like there is hypotonia, there is muscle weakness, there is fatigue. And even for the paralytic ileus or even for the gut, movement of the gut will be decreased like that. So you have to assess for these things to give us some idea about what the situation of the patient. And as we mentioned, it is better to prevent this complication to happen from beginning. And that's why many times with the rush and difficulty, and sometimes also with availability of the resources, we forget to add, sometimes if we don't have ringer lactate and whatever like that, sometimes if we start the normal saline, we have to put at least for each liter is 20 milli equivalent of potassium. Sometimes this is not available, or there is shortage, but I hope this there will not be like there will be no shortage in this because it's life saving. This drugs like that, it is very cheap, relatively. I know there is some difficulty to find them, and we can encourage potassium-rich foods like banana, jawfa, and what locally available. But this, generally for jawfa, usually still better. You use jawfa after banana. Jawfa is having good amount, but the problem with it is also like some fibers or something like that. So little bit incompatible with highly inflamed gut in comparison with banana. So banana can be introduced. The earliest one can be introduced generally is banana. Then jawfa. Orange juice also can be introduced, but initially also because the amount of the sugar, so it can cause also increase gastric, the gut output by causing of fluids, by causing osmotic diarrhea. So it can worsen the situation initially. But well known, orange is getting also good amount of potassium. And encouraging potassium-rich foods, it is important where it's not only in the acute stage, but also in the recovery stage, because the total body will be highly depleted in potassium. And even if we check initially the potassium of the plasma or the blood, and we found it normal or near normal like that, but the total body amount, it will be highly reduced. That's why the patient need to be encouraged them in the rehabilitation time or recovery time to take potassium-rich foods. Because after starting food, what we know, there is something we're going to speak a little bit about it later on, refeeding syndrome. Other complication is like hyponatremia and hypernatremia. Both of them. Hyponatremia and hypernatremia can occur at the beginning or can be occur during the treatment itself. So now let us speak about hyponatremia, decreasing sodium level. What is the clinical signs also, because we need to look for the signs. In comparison with hypokalemia, where there is decreased movement or weakness or hypotonia, these things like that, here it will be like more of irritability and seizures maybe. Okay, ask also about symptoms, or in the history, like sometimes of overhydration, sometimes. It can cause, sorry, I'm speaking about hyponatremia. It can cause hyponatremia. Okay. One of the causes of hyponatremia is the fluids, plain fluids. or dilute ORS because it's content of low sodium. So this will enhance the shifts of body to get like hyponatremia. So even the dehydration with time, it will be switched from isonatremic to hyponatremic dehydration, which can cause a lot of complications. As you mentioned again, how to avoid it. We need to avoid it also. The best things is to avoid the things or the complication to happen from the start or from the first presentation of the patient, to think about how I can avoid the complication. So by avoiding hypotonic fluids, and sometimes people, and this also for, sometimes we need to, for awareness for the families, and sometimes at home they used till they come to the nearest health institution, clinic, or whatever like that. Sometimes they used to give a lot of hypotonic fluids or plain water for the patients at home till reach. This also can compromise his electrolyte balance, especially the sodium, and can lead to hyponatremia. One is a very important problem. Sometimes correcting a complication fastly or inappropriately can lead us to another complication. So that's why you have to think in a wise way to how to treat a complication without endangering the patient to go or undergo another complication. So for example, if the patient is having hyponatremia, so it's a kind of complication of cholera, especially for severe cholera, and especially for those who got, as we mentioned, like hypotonic fluids. One of them, if you correct it fastly, we can cause a problem, which is osmotic demyelination syndrome. Okay, so this currently we can cause osmotic demyelination syndrome and can affect the nervous system, can hit the nervous system badly for the patient. There is different forms of it, but this is generally the umbrella of this term. So if the patient is having hyponatremia, as well as we are going to come in the next slide for hypernatremia, we have to correct nicely, because here for hyponatremia, fast correction, it can make for us to go on osmotic demyelination syndrome, while in hypernatremia, for the fast correction, we can go to brain edema. Both of them is dangerous for the nervous system. Now speaking for correction for it, for sure, slowly, using WHO ORS, and it will help us to reduce, and if there is a patient already on hypotonic fluid, to stop the hypotonic fluids he's getting, to make sure that he's getting good fluid balance, like that, balanced fluid, either IV or oral like that, like if it is oral like ORS, not be diluted, because sometimes there is, with the rush, sometimes there is some issue or some mistakes or errors in preparation of those fluids. For hyponatremia, also it can present with large sheets either, so there is some overlapping between hypernatremia and hyponatremia. We can imagine, like for hyponatremia, when there is more of water, here will be less of water, so the fluid will be more concentrated on comparison for. So always ask, see the progress, how the patient was being treated in the previous time, like that. Okay, so this will help you to diagnose besides the symptoms. And both of them, as I mentioned, to be corrected slowly, because both of them, if corrected fast, can lead to, as we mentioned, hyponatremia, can lead to demyelination, and for hyponatremia, fast correction can lead to cerebral edema. So what is the risk precipitation? As we mentioned, if the patient is getting inadequate water intake during diarrhea or vomiting, or there is delay of rehydration. or we gave him high sodium containing fluids. It can happen. Yeah. Management, as we mentioned, we have to give the patient gradual rehydration with ORS, and even if we give him IV fluids, it will be also gradual correction for it. Now coming to other complication, which is hypoglycemia. Hypoglycemia, like the signs would be like some disturbed liver consciousness, sometimes seizures, decreased body temperature, and for children poor feeding, like that. And as we mentioned before in the introduction, or in the slide where we mentioned like who people at risk. Who are at risk of hypoglycemia more? Children, and especially children less than 5 years. And the younger the child, the more the risk to get hypoglycemia, because for their more demand of energy, less reserve of glycogen in comparison with their need, like that. So the depletion can happen fast for them. So that's why we have to think also about in hypoglycemia, especially for the children less than 5 who they came like with clinical signs supporting. How to manage if we having an IV access available, and if we have dextrose 10%, we can use it to give 2 ml per kg intravenously. But many times say there is no access, or we don't have even 10% dextrose. What we'll do, simply just to rub sugar or any like glucose containing containing solution, or honey if it is available in the gums. This is highly absorbing area, the gums. So just we can rub it nicely there. This will give us some time, and will start to improve the level of the glucose. And also correction will be slowly for the patient. Each of osmolality like that. Okay. Now we go for acute kidney injury. This one we have when to think about it. For sure, there is, as we mentioned, people who are already having kidney problems, elderly people, people is already having like significant hypertension or diabetic. Those are more risk to get acute kidney injury. And the more the severe and prolonged the dehydration, the more to get the acute kidney injury. We want to think about it generally also, because also we are limited in the resources and they take the labs and these things, and even as you mentioned, many times it's not available, or even like the report will be a little bit delayed. So what we can do, also clinical judgment is very important. So if there's acute kidney injury, usually characterized by decrease or urine output, it will be, sorry, there is the acute kidney injury, especially when significant, there will be no urine output. Sometimes there will be signs of fluid retention. This could be like puffy face, and also signs of poor perfusion despite adequate hydration. So the patient, the degree of the patient of dehydration may be dealt with it in a good way, but despite that, the patient is not showing signs of recovery. So it is out of proportion. The response is disproportionate with the way of hydration, like that. Okay, so still the patient will be also, and he looks the weight and these things because there is fluid accumulation. So urine, especially if there is no urine output for more than 6 months, any signs of fluid retention here or there, like in the face, and signs of poor perfusion despite adequate hydration, let you think about acute kidney injury, for sure, with a compatible history, like the degree of dehydration happened before, and the patient also comorbidities. Is this patient is elderly? Is this patient is having already a kind of chronic kidney disease, or is having like significant hypertension, or especially if it is uncontrolled hypertension or long-standing hypertension. How to manage? We need to monitor the patient for sure. and to adjust the fluids, not to overhydrate the patient because already he's having his kidneys affected like that. If the patient is getting potassium in the fluid, it stops the potassium because his renal is affected. There is no renal excretion of potassium, or at least affected the potassium. So we have to think about that, the fluid amount and the fluid content, and how to monitor the patient. And to think about also how we can, like, especially the patient is having, there is no improvement, because sometimes the patient start to improve gradually, start to recover, the urine is going to come back, the issue will be these things. Then you see also the fluid is getting less accumulated fluid like that. So hope that there is a patient that you can refer him maybe to another health institution to relate it, or guarded or by Ministry of Health like that, to some place to see this patient, because he can treat in your place like that. We know that there is a lot of issues about resources and that, but we hope that things will get better, and inshallah. So this is generally about talking in this slide about the complication of acute kidney injury, how to look for it, and how to manage it, and how to monitor it. One of the complications, especially with cholera, is malnutrition. Many people who already borderline malnutrition or already malnutrition, so they can start the problem of malnutrition during the illness itself. And you know that sometimes the cholera can take some quite long time, and the patient cannot tolerate food, maybe only replacement with the fluids and electrolytes is not sufficient for him. So the complication of malnutrition can happen, especially for those who they're already having some kind like borderline. One of the problems with the malnutrition, or those who are who are malnourished or get malnutrition during the cholera itself, is, as I mentioned, is refeeding syndrome later on. So refeeding syndrome, we're going to speak on it maybe in the next slide. But there will be a problem of distribution of body fluids and electrolytes after the patient is going to start getting food, especially if it is high in high protein, high sodium, high these things like that. Okay, so and high calorie. So usually that's why WHO generally recommend to use F75 formula in the first 7 days, usually in the first 7 days, to avoid refeeding syndrome, especially for those who are at risk of refeeding syndrome. You can assess. There is something called risk assessment. At the end, I kept some references you can find, like in WHO regarding malnutrition, refeeding syndrome, and whatever like that. You can go through it. But generally, we have what we do is what we call it like risk assessment, to assess your patient. Is this patient at risk of refeeding syndrome or no? There is specific criteria to look for it. Like for how long this patient was not taking any any food. How the patient himself now, the nutrition, also body mass index, or whatever other parameters to get like his weight, whatever like that. Was he already borderline or malnourished before? Those who are high risk of to get refeeding syndrome, and by the way, refeeding syndrome can kill without being noticed, and it is under recognized and under tackled, as I mentioned in the beginning of my speech. Now coming to the refeeding syndrome itself, and as I told you many times, it is overlooked, but it is real is a problem. Now even in Sudan, there is issue of malnutrition because of also the war, displacement, and resources, and whatever like that. So there is two things, cholera on top of malnutrition. This combination is not good at all, because each one of them is going to act for another, like reciprocal effect for each other. So what is refilling syndrome? It's life-threatening fluid and electrolyte shift in a simple definition. يعني it's life-threatening fluid and electrolyte shift during refeeding from the name. So it is refeeding. And usually start is not during the patient getting IV fluid, whatever the kind of severe dehydration, patient in shock. This is not the time to think about refeeding syndrome. Refeeding syndrome, think about it when the patient is going to improve about the diarrhea, the fluids, and start to take orally food. Okay. So what is the clinical signs? Usually related to the electrolyte disturbance. Like you can find weakness, confusion, and this usually can happen with hypophosphatemia. Okay, the many electrolytes can be affected, but the main three electrolytes are affected is potassium, magnesium, and phosphate. So the main three electrolytes affected in refeeding syndrome are those three: phosphate, potassium, magnesium. Okay, to think about this. The good thing is that many of the food we use it for high rich in potassium also. Many of them are good in magnesium and phosphate. So as we mentioned, so let us look for the signs, clinical signs. So for example, if the patient is having like weakness, confusion, maybe think about hypophosphatemia. Arrhythmias, for sure, think about hypokalemia. Okay. Tremors and seizures, it can happen more with hypomagnesemia. Okay, sometimes, and as we mentioned, like because of the definition and according to the definition, it is not only electrolytes, it's also fluid. So also look for the features of heart failure. Okay. You have to look for the risk factor, as we mentioned, like severe malnutrition, prolonged fasting, and aggressive refeeding. How to prevent it, as we mentioned, WHO also recommend, especially for those who are risk, is to give 1 to 7 days of F75 before going to the high calorie like F100. And to monitor electrolyte if it is available. Supplement electrolyte at least in foods. Okay, this is very important, and to make that sure the patient is getting good source of electrolytes. This is how to monitor the patient or complication, like you are in a camp, or you are working in the clinic seeing patient, or I mean in setting of hospital or whatever like that. So generally, especially the assessment will be more frequent in the first, in the initial minutes or hours. So initially, you need to assess the patient every around 5 to 30 according to the patient situation, whatever like that, during the initial rehydration. And you have to think about, and I try to keep this one practical, to think about these 5 parameters: mental status, you know, drowsy, and how is his condition? Is improving or worsening like that? Okay, like he was drowsy, now he's comatose, or he was drowsy, now he's fully aware or awake. Look for the pulse. It will tell you about the dehydration, tell you about maybe electrolyte disturbance. It may tell you about the potassium, arrhythmias, these things like that. Look for respiratory pattern. If the patient is hyper metabolic acidosis, so he try to compensate by CO2. Or maybe if the patient is having more also distress, maybe he start to have pulmonary edema, like that. Okay. Look for the skin also, hydration is hydration. For urine out, or show you about the patient, about his recovery like that. Initially, it's not passing or little. Or this one you can, after all this, these 5, and sometimes the people are busy, there's a lot of things, but it's very important to make your life easy and other life easy, and also other to make your life easy is to document the hydration status, at least in few lines about. So this will help you when you come back to the patient, or when you hand it to another shift or whatever like that, according to the situation, whatever the issue. It will help you a lot, okay, for monitoring. I think now, because I brought some case scenario, but because maybe of the time, I'm not sure of if we can go directly to the questions or we start with the cases. What do you think, Sarah?
We can take some questions, and if we have some time,
Okay.
let's do the case.
Okay.
Please,
Dr. Nagi, thank you very much for the comprehensive and very nice presentation. I just wanted to let you know that you had more time. We'll be moving into another Zoom for our meeting, so please you can take your time in the session. Thank you.
Okay, shukran, shukran. Thank you so much. So if there is no questions, we can proceed with case scenarios.
yeah.
Okay, so for the case scenario, I made some, like, if the time allows, I made around 6 cases, and I want the audience participation to be interactive. For each scenario, I'll give a brief about the case. Then the question may be minimum 2 questions, maximum 4 questions for each. Then we start by question one by one. Question 1 we'll ask, then we see the audience. And it's up to your preference. You would like to participate by using directly or speaking or by chat. Then after finishing the case discussion, and there is a question, we'll go to the next case till the time finish, inshallah. So we'll see how many cases we can go through them, inshallah. Okay. So we'll start with the first case. So we have an 11-month-old child brought to the clinic with history of profuse, painless watery diarrhea. I put it in bold here just to show you that this is typical of cholera. It's usually profuse, large amount, and usually it is painless, and usually it is highly watery because it's secretory diarrhea, usually like that. Okay. The patient is lethargic with reduced activity and poor responsiveness. He's having sunken eyes, dry mouth, and no tears when crying. He's having no urine output for the past 8 hours. His pulse is weak, and he's having cold extremities. The settings you are is in limited resource setting, and you have a minimal monitoring tools available. So for the questions, question number 1. Okay. How would you recognize hypovolemic shock clinically? This patient, do you think this patient now clear? The patient is severe dehydration / hypovolemic shock. How we check hypovolemic shock clinically with limited resources? Sometimes even you don't have even other monitors like that to say no oxygen, no these things. Sometimes even blood pressure is not working. Just few comments.
You can raise your hands and open the mic to answer, or just write down the message. Who want to answer this question? There is an answer: the pulse rate and the capillary refill time.
Excellent. Excellent. Excellent way. So from it is very, very important to mention, because we are the idea here. I know that all of you, mashallah, you know how to deal, especially with such cases like that. But the idea for many reasons, because it is fast, it is in our hand, it can give us a chance to give a fast decision, and we know that the limited resources that we have. Maybe some places in Sudan now is better than others, or will depend on which you are working in, maybe a relatively stable city with some, but maybe you are working in the camp. So we have to open our mind for whatever circumstances you have to. So simply, like the symbol as the symbol of the clinical reasoning steps, we have to collect information, analyze this information as fast as possible. This from the history and from examination as much as possible. From the history about from the mother or caregiver, how long this will help you even to see how the degree of dehydration, how long the patient is having, how much amount the diarrhea is having. Is he having his past urine? When's the last time he passed urine? How's the color of the urine? Whatever like that. All these things will help you. How he's communicating with you. He's communicating and not communicating. Does he is drinking, not drinking? Okay, this will help you. And as you mentioned, by the examination, capillary from general CRS examination, conscious level. As this patient now, you can see the sunken eyes, skin tear, and this will tell you about this degree of dehydration, but very important, as the doctor mentioned, the heart rate, fast and steady, and the capillary fill, it will be, and extremities will be cold, generally, with prolonged capillary fill time. This is very important things, okay? So we go, what's your immediate management priorities? If IV is, okay, maybe a question, okay. What are your immediate management priorities if IV access is available? So you have the IV access. What you are going to do for this patient?
So, can I answer, please?
Yes, sure.
We would try to give Ringer lactate since he is less than 1 year. We would try to rehydrate him in 6 hours. So
Excellent.
it would be like 30 ml per kg in 1 hour and then 70 ml per kg in the rest 5 hours.
Okay, because he is less than 1 year. Excellent. If he's more than 1 year, okay. Excellent, well done. So what would you do if IV access cannot be secured immediately? There is no IV access. What will you do?
In such case, we would try to give NG tube. We are giving ORS, WHO ORS solution.
Excellent. So you can give it like flu like or free or as a or maybe like as a continuous ongoing fluid from the ORS. It will be just like as you're giving IV fluid. Excellent. Would you like to give this patient sips of water? This patient, you give him sips of water? Actually, this patient not going to give him sip. Directly, we try to insert the NG tube because his level of consciousness is not there. So he's having poor response. So there is he's at risk of aspiration. The sips, whatever, it will be very few. It's not going to replenish his significant, he is in shock like that, okay? So we no need to waste our time directly to go to insert the NG and start the fluids. Okay, for the next case, scenario 2, this also a child, but this one is 3 years old. Okay, 3 years old child brought with 3 days of diarrhea and poor oral intake. He's lethargic, confused, is having confused behavior. He's having sudden onset of shaking movements. These are described by any caregiver, but it's clear like a convulsions. So, and you don't have a glucometer available in your site. And also the setting is resource limited and no immediate lab testing available. What you are going to do for this patient? Questions. What could be the likely complication? And with the complication we mentioned already in previous in the talk in the speech like that, what do you think? There is for sure it could be many things, maybe whatever, like just give me differential or what you are thinking, differential or maybe most likely judgment. Okay, I'll try to help you. He is a child. He's less than 5 years. If you see here, the diarrhea is also for what good time, 3 days. His lethargic and confused behavior, something affecting maybe his mentality or CNS. And he's having seizures also. Okay. And they told that there is no poor intake. He's not taking well. And he is a child, as these things. And we thought that children are at risk of hypoglycemia. So this child may be, we're not sure 100%, but this is a kind of child who is at high risk of hypoglycemia because he is a child less than 5 years. He is having this diarrhea and having poor oral intake for 3 days. And he's lethargic, confused behavior, and he's having convulsions. So less likely here at this state to have hypernatremia or hyponatremia or these things. Okay, it can be. So this may be in the second, but this is the first one to think about it is the hypoglycemia. What immediate action would like to take at the bedside? So now we have this child and he's convulsing. Just now stop, maybe you control the convulsion, stop by itself. Now what are going to do for this child? We're thinking now, priority now, that this child is maybe is hypoglycemic. Try to participate, whatever. It's open. نشوف الشات. Not sure people are not in the chart or no. Maybe we'll see here. Yes, okay, excellent. People are writing the chat, right, excellent. IV dextrose, it is available, excellent, 10% dextrose, 2 ml per kg, excellent. If it is not available, we can, as many of you mentioned here, yes, honey on his gum or sugar or something. Okay, excellent. Okay, I'm sorry, I didn't see the comments initially. Okay, well done. Excellent. So now we go to another case. Now we are dealing with pregnant women. We have the scenario like that. You have a 32-year-old woman in her second trimester of pregnancy, presented with moderate dehydration following several days of diarrhea. She reported that she's feeling that the fetal movement is reduced. The setting also, it is limited results, basic monitoring only available. Okay. So now we come to the questions. Question 1, how would you manage her hydration? How you are going to manage her hydration? See the chart. Okay, Ringer, excellent. Ringer rotate, IV, excellent. I would treat her as moderate, as I mentioned here. They mentioned already she's having moderate dehydration. Monitor fetal heart rate, excellent. So Nusaiba, she answered the next question. If you can monitor the fetal, but even sometimes, even we cannot monitor the fetal heart rate, what you're going to do. Now we'll go to the next. So we'll treat her carefully with fluids. And we know that, as we mentioned, she's pregnant. She and her baby at risk of complications. So we have to be very careful. We have to rehydrate her, but we have to remember that sometimes pregnant ladies are at risk of pulmonary edema. Okay, so we have to rehydrate her. We come to the next question, which is partly answered by Shaiba, I think. Okay. What key aspects would you monitor for both mother and fetus? I mentioned about the mothers, look the hydration and look for respiratory issues and edema and how because she's at risk of a complication. So we need close monitoring. Although even she came with moderate dehydration, but I have to keep an eye open. And this is very important because when we deal with patient, we deal with patient individualized. And we deal with the patient as individuals. This patient is moderate, but she is pregnant. It will be different than moderate dehydration in a 32 years old woman. 32 years old woman who is malnourished, it will be different than 32 years, which is well nourished. For all these things is going to. So here, how is going to monitor the fetus? Or what are going to do for this patient? See the chart. Monitor fetal heart rate. Okay. So if you don't have the fetal heart, you cannot monitor. Excellent. If it, but we don't have no way to monitor the fetal heart sound. A very simple thing. What we need to monitor, maybe here, CTG. Good if you have CTG, but we don't have CTG here. And I'm trying to keep excellent, but I'm trying to keep things at minimum. Okay, excellent. And someone mentioned fetal movement. Excellent. You have something in your hand. You always think about what you have in your hand. Here I'm having at least the fetal movement. The mother herself, she can tell me about the fetal movement. Is the fetal movement is there or stopped? It came or there is no fetal movement at all. That time I can maybe react or try to transfer her to other institution with some facilities like that. Okay. But all you mentioned is highly valuable, really. Excellent, well done. Now we go to the next question. Okay, when you decide to refer agency, as mentioned, if there is no fetal movement, stopped. Okay, or the mother develop a kind of, especially for this one, we have to refer her. Other maybe complication for mother, maybe we can treat it, unless it is very severe, we can treat it here, but we have to be very careful. Okay, now we came to case scenario number 4. You have a 72-year-old man is brought in after several days of severe watery diarrhea. He has moderate dehydration. He has not passed urine for over 12 hours. Setting resource limited and no immediate lab testing available. Questions. What is the likely complication of this patient now? What do you think? There is maybe many, but what is likely, and you think about it here? Excellent. نسيبة جاوب صح. إسراء كذلك. شيماء. Well done. Malaz. Okay, you are right. All of you are right. You also think about AKI. As you mentioned, elderly man is the one of at risk of complication because already many of them they having comorbidities. Besides, so we have an elderly man, the context. We have the severe watery diarrhea for several days, severe watery diarrhea. So there is significant fluid loss. Although when he came now, he is having moderate dehydration, but this will not exclude what happened to his kidney, how it's been hit later. He's not passing urine for over 12 hours. If the patient is not passing urine for more than 6 hours, this is alarming sign. So here we have to think about complication here, acute kidney. If this patient is taking now any fluids, including potassium, I have to stop the potassium. I should not give him potassium now. Okay. Now we go to the next question. How would you manage his fluid differently? Mistakenly, I mentioned, but anyway, we have to reduce the amount of the fluid to the amount and the potassium. So the amount of the fluid, although even if he's having moderate dehydration, we're not going to treat him like the patient who's having moderate dehydration with the same amount. We have go slowly and observe him because he's having renal, maybe acute kidney injury, but you have to make sure that also he's getting enough hydration, because maybe his problem can be reversible. Okay. What key points would you monitor closely in this patient? Yeah, you're going to monitor him how, what things monitoring closely for this patient. Excellent, excellent. Serum potassium, if I can do it, it's very important. If I can, electrolytes, mental status, well done. Pulse rate, excellent. I have to check his pulse rate quality, because if this is potassium, his risk of also hyperkalemia, whatever like that, or electrolyte disturbance, he can get like maybe arrhythmias or whatever like that. Urine output, very important, excellent. Okay, if he's passing, start to pass urine or no. Excellent, well done. Important since, okay. Now you go to the next question. This is another scenario. Now you have adolescent being treated for dehydration due to diarrhea. Say it is watery, diffuse, profound watery diarrhea like that, okay, typical of cholera, whatever. He refused to drink ORS. He's not willing to take, because of the test. Instead of that, he was given large amount of plain water. After a few hours, he developed, when he arrived after a few hours, he developed sudden seizures. Also, you are resource limited. What do you think? What do you think? Question now. What do you think is the most likely cause of the seizure? Maybe there is a lot of things, but one of the things you have with this context, what things you have to think about it? Fluid overload, hyponatremia, excellent. Maybe you fluid overload, yes. But if he is taking fluid overload, what kind of fluid? He's taking water. And if he's taking only plain water many times, he'll be delusional hyponatremia, as Shema mentioned. كله برضه آيات mentioned, Odysseus mentioned hyponatremia, well done. Excellent. So we have this is typical of a patient developing like hyponatremia. If the patient is taking, he's having diarrhea, and he's taking hyponatremic fluids like that, he can develop easily hyponatremia, and he's having complication of it. Okay. How do you manage his complication immediately? And after case 5, we have only one case. How are we going to manage this? And what should be caring for? Slowly, okay. Okay. We can replace, if we have hypertonic saline, if we can, usually normal saline, excellent, yes. To avoid this one, yeah. Excellent. And slowly, to make sure that things is not getting worse. طبعا these cases, the 5 cases, sometimes it depends on the facility you are working in. You are the same doctor, like Dr. X. Maybe today I am here in one camp with no any facilities. Maybe after a week or 2 weeks, I'm in another place in a hospital, a fluid restriction. I'm going to restrict the water or hypotonic fluids. You are right. Excellent. Okay, well done. And to monitor as we mentioned before. Okay. Now we come to the last case. 38 years old, malnourished woman in a refugee camp. She's having a recent cholera infection. Her diarrhea resolved. She started in high calorie feeding rapidly. After 48 hours, she's having weakness. She's having muscle cramps. She's having confusion. By examination, she's having tachycardia and hypotonia and decreased reflexes. You are in this refugee camp with limited access to facilities, including labs. Okay, so what is the most likely complication here in this case? See, excellent. ملاذ، نسيبة، نهاد، شاعر، كلكم رايت. ملاذ، آيات، well done كلكم. Refeeding syndrome, yes, you are right, absolutely right. Okay. So we looked at the whole context. يعني she's already malnourished, and as we mentioned, يعني those who are malnourished, they're having more risk of complication and more risk of refeeding syndrome complication. And the time, so when we look for the time when the problem happened, it does not happen during the acute illness or diarrhea itself, but it started when she's having start to get high calorie. So here, the issue is how refeeding syndromes happen. The patient in depleted, you have low level of insulins because he's not eating, and there is issue about the hormones, and he's losing a lot of electrolytes. Even as you mentioned, even if you check the electrolytes from the blood of the patient after resolution of the diarrhea, but the total body electrolytes will be depleted, especially potassium, magnesium, and phosphate. Okay, those. So usually, when the patient is going to start to eat, so that now there is food, now insulin is going to work, now they will be shifting, there is glucose now, here and there, and the potassium, which is outside, is going to be shifted inside. So the patient is going to have hypokalemia, and also other things like hypomagnesemia and hypophosphatemia. Okay. So this is, as you mentioned, this is compatible with refeeding syndrome. Okay, now coming for which electrolyte abnormalities are likely. Maybe I answer, but let us see from you. يعني هو ايش electrolyte disturbances usually can happen in refeeding syndrome? What are? hyponatremia ممكن، لكن is not that أو لو لا أنا مش كنت دخلتهم فيه. اوكي اوكي hypokalemia. اوكي magnesium phosphate. Excellent. So potassium, magnesium, and phosphate are mainly really affected in refeeding syndrome. Okay. So usually for such patient, how should you manage her? يعني this patient, how are you going to manage her to avoid this, or now, or already she start to have refeeding syndrome? How are you going to manage her slowly? Okay. Excellent. Malaz, you're right. Okay. Let us see who's first writing to give chance for others. Okay. So if she's what high color diet, we're going to stop. We are going to reschedule her her feeding program. We're going to decrease the calories. We're going to increase in the first 6 days, as Malaz mentioned, usually as this WHO recommendation. We give her F75, not high calorie formula. F75 has 75 calories per each 100 ml. And also we make sure that she's getting rich like banana, jawfa, these things, because they have a good amount also of dismissed electrolytes. Okay. Sometimes, if you have good facilities, there is some, you can go also for the WHO recommendation for refeeding syndromes like these things. You can find some information there also. But this is general idea about it. Okay. I'm thinking this maybe is the last. Or there's or how can you avoid this complication? يعني say this patient, now you have a patient, and now this complication maybe can be avoided from the beginning. So how we can avoid it, this complication from the beginning? And we have a 38, she's having diarrhea. You're going to start fluid. Sorry, you're going to start food for her. Maybe already you answered, but let us hear from you again. Okay, excellent. Malaz, Ayad, Isra, you are right, all of you. مشاعر كذلك. You are right, excellent. So we are not going to, if this patient and coming from the beginning, and I am aware about the refeeding syndrome, I am going, because this patient at risk, and I said there is a risk stratification for refeeding syndrome. You can find this all details in protocols, the WHO protocol for this thing, but there is risk stratification. Who are at risk of? One of them is malnutrition status, if the patient already malnourished. One of them is the duration of the severity of diarrhea. One of them is how long the patient he didn't take, or is the longer the time, especially if he reach around 7 days, like that will be at high risk. And we have to keep in our mind, most of our patients now, if not malnourished, they're borderline malnourished, okay? I think we came to the end of the presentation. So I kept here some slide just to conclude for some important message, just so you can take it with you. The early correlation and prompt management of complication are critical to saving lives in cholera. Yes, it is without, as we mentioned, mortality is significantly high without intervention, but the earlier the intervention we can, and the fast and the appropriate, we can avoid the complication. Shock, electrolyte imbalance, hypoglycemia, malnutrition are major life-threatening complications. So don't only think about the loss of fluids, but think also about electrolytes, hypoglycemia, and malnutrition refeeding syndrome. A careful fluid resuscitation is the cornerstone of managing hypovolemic shock. This is very important because it's one of the leading cause of cholera deaths. Severe dehydration, and it is associated with hypovolemic shock. Malnourished patients require slow refeeding to prevent refeeding syndrome. So remember, when to refeed slowly. Okay. Clinical monitoring is essential, especially when laboratory support and other sources or resources is limited, like in the settings we have. But we have our clinical judgment, and I believe that most of you or all of you like having good clinical judgment and excellent physicians. And this also applies to our nurses and, as I mentioned, health care providers and also other allies. Thank you so much. There is some references here at the end. There is other references, but this is the main maybe reference you can go through it. Okay, thank you so much for giving me this nice chance.
But Nadi, we can't thank you enough for the very fruitful session and the nice scenarios. It really helped in consolidating the knowledge about this vital topic. Most of us are healthcare providers, giving scenarios close to the reality will make the performance really better. So I think this session was very informative, and thank you so much for giving us.
Thank you so much for this nice feedback, supporting feedback. I'm really happy to be here with you. This is the least we can provide for you. And as mentioned, I'm really proud of our physicians, doctors, and all who are fighting the disease and trying to make things better in Sudan. Telling them they are bringing like candles in the midst of darkness, and hope out of despair. Thank you so much, really. It was my pleasure.
Any comments or any questions for Dr. Nagi?
Hello.
Yes, hello.
Hello all. I pre-share this course and I am sorry for not attending this course from the beginning. I'm Nihat and I am pharmacist. Maybe there is some issue I can understand it because it's related to medicine more than pharmacy. I'm a pharmacist and I work here in Blue Nile as IRC staff. And there is a collaboration work between us and MSF, which is treat malnutrition here in the Blue Nile Hospital.
Excellent.
Yeah, there is a main problem here after treatment of malnutrition children, and they are discharged to our home. They are come back in worse situation more than the beginning.
This is very.
So, yeah, this is very serious here. Complication here we have it here. And now I can understand this is one of the refeeding. I think this is refeeding syndrome after discharge.
Exactly.
Because mothers and family cannot, they can't understand the new feeding of the malnutrition at home. Am I right?
You are absolutely 100% million right. First,
Yeah.
thank you for sharing your experience and bringing this point, which is very important and valid point like that. And
Yeah.
you are exactly right. Actually, this problem is underestimated. Actually, the refeeding syndrome. And by the way, it happened for some of detainees who have been detained for a long time and went to after release them and they go to hospitals or whatever like that and start to get they got sick and we lost some people, even I know them myself, okay, because of refeeding syndrome. Refeeding syndrome is a real problem, the real problem. Here, maybe I will tell you here in we see it here, maybe because there is no malnutrition as these things, but we see it, we take with them carefully. We have cases of anorexia nervosa. We have cases of sometimes who are especially developmentally delayed, or those who are having cerebral palsy, or there's something, things like that. Some they're having abdominal surgeries, so they'll be off for a long time. And you can astonish because we have the facilities to do, the levels and the ECGs and these things. You can astonish by the problems those kids they are going to face without thinking about this refeeding syndrome. And the same problem also in Sudan, and especially as you mentioned, like refeeding syndrome can happen to anyone, especially for those who are malnourished already or borderline malnourished, which is most of the kids now are in this problem like that. So these things I think need to be aware, to increase awareness like that about this problem, because the families even they'll be very happy after kids they get well, and like their feelings like, oh, now I'm going to compensate you, I'm going to this one, I'm going to get you come back, whatever you like, I'm going to give you these things later. So this is a real problem. It can kill, it can kill, make complication, whatever.
Yeah, we're facing a lot of these cases here due to this situation, really.
Yes, you are right. I agree with you. I think this issue may be need to be raised up, but starting from this, maybe talk like that. Maybe other people, or maybe who listening or with us here, even like making like small, maybe like a voucher or something like that, or some booklet small, just like one paper, just like talking about refeeding, about it will be one maybe in English, little bit, this one for doctors and another one for the families to understand this issue like that.
And I think the main problem here is with medical staff who are in hospitals, they doesn't know. I'm sure most of them they didn't know about it.
Yes, yes, you are right. You are right.
Thank you, Dr. Nadi.
Thank you so much,
I think
Leila.
this will be my new beginning.
Okay, thank you so much.
Thank
Happy
you.
that I add something, يعني. You make me happy, really. Thank you so much.
Yes, thank you.
Alaikum. Hello, Dr. Nagi.
Yes, Ahmed.
I don't have any question, but I just wanna say thank you very much for your informative and well-organized session. And it's really such an interactive presentation. So thank you so much for it.
Thank you, Ahmed, so much. And thank you for giving me this chance and thank you for your participation and for nice words. And I'm very happy to participate, inshallah, in future talks or speech like that. Thank you so much.
Okay, by now we conclude our session for today, and this is the end, but not the last. This is the end of the diarrheal disease echo series. But keep engaged, keep in touch, and um, for more echo series and other activities of SAMA, follow us in the Facebook page, in WhatsApp. So you can catch all the activities. We can't thank Dr. Nazi enough, and we hope everyone get benefit, and see you in the next sessions, inshallah. Another kind reminder, you will all have the recorded session and the certificate just by filling the feedback form. After filling the feedback form, you will be the certificate will be sent to you. So thank you everyone for joining, and see you inshallah the next time.
شكرا جزيلا. Thank you so much, Sarah. Thank you so much.